My name is Bob Smith, and I'm on the board of directors here at the Scleroderma Research Foundation. It's been a really great day so far. Whether you've been here from the start or just joining us now, I'm so glad that you're part of this event. I'm also honored to introduce the next session, Advances in Pulmonary Arterial Hypertension, or PAH, Research. But first, I have a few comments before we start. For those of you who have already heard these notes, thanks for your patience. As always, we welcome any and all questions you may have. Please submit those in the Q&A panel on the left of the screen. There will also be a short survey at the end of the session, and then we'll automatically go forward into the next and final session of the day. Now, it's an honor and privilege for me to introduce someone I've known for several years, Dr. Roham Zamanian. Dr. Zamanian is Associate Professor of Medicine at Stanford University School of Medicine. He specializes in pulmonary vascular disease, which includes PAH. Dr. Zamanian is considered and recognized as one of the leading national and international experts in clinical trial design and drug development for PAH. Thank you, and here's Dr. Zamanian.
All right, well, thank you very much for that lovely introduction, Bob. I'm Roham Zamanian, as you've already heard, and I'd like to take the time to talk to you about updates on the diagnosis and treatment of pulmonary hypertension, really research concepts that are relevant to systemic sclerosis-associated disease. Just share with you my disclosures. There's nothing that's going to impact my work here, but here are my disclosures so that you know. And you know, the discussion we're going to have today is about updates on the classification of pulmonary hypertension. Really, what is pulmonary hypertension? What are the hemodynamic definitions of this disease? And we have some new ones that are relevant, and updates on the treatments. So just starting with the classifications of pulmonary hypertension. Pulmonary hypertension is a broad syndrome of diseases caused by different etiologies. The one that's most pertinent to systemic sclerosis is the group 1 PAH associated with connective tissue disease, labeled here as 1.4.1. But the reality of scleroderma and scleroderma lung disease, as you will hear or have heard already, is that there is overlap with other relevant causes of pulmonary hypertension, including the interstitial lung disease that forms in patients with scleroderma. The fibrosis of the lung is also by itself a potential cause for pulmonary hypertension, and also some cardiac causes. Basically, group 2 and group 3 causes for pulmonary hypertension are relevant to patients with systemic sclerosis. So, you know, we are always very careful to make sure we understand and what we call phenotype, to understand how the disease is formed and what are the other, if you will, organs that are impacted by systemic sclerosis. And in this case, not only do we have the pulmonary vasculature that are being impacted, but also the lungs, the meat of the lungs themselves, and the heart itself also. And the last thing I want to mention here before we move on to the other slides is under Group 1 PAH, there's a population called Group 1.6, patients with pulmonary veno-occlusive disease. This is a common finding in some patients with systemic sclerosis, and it complicates our therapy. It is basically a condition where the therapies actually sometimes cause a little bit more harm than good. So we always have to be careful about blood vessels in the lungs that are on the venous side that are affected by systemic sclerosis. So now that we have seen the sort of the broad overview of classification of pulmonary hypertension, how do I, as a clinician and a researcher, diagnose pulmonary hypertension? On the right-hand side is a schematic looking at the blood vessels, and on the bottom segment is a blood vessel that's completely occluded and what we call a plexiform lesion. If I could diagnose the disease by biopsying the lungs, I would, but that's a very dangerous proposition, and it's never done in pulmonary hypertension. So when a scleroderma patient sees their physician and has symptoms like shortness of breath or other symptoms that point to the lung, we always evaluate them for pulmonary hypertension. Pulmonary hypertension is diagnosed by a right heart catheterization, where the catheter goes through the neck or the groin into the lungs and through the heart to measure the pressures in the lungs. And pulmonary hypertension is defined as a mean pulmonary artery pressure, a mean pressure, not a systolic pressure, but a mean pressure of more than 25 millimeters of mercury. There's recent data that shows that a mean pulmonary pressure of more than 20 millimeters of mercury by itself can be diagnostic of, either early or established pulmonary hypertension. And this is really relevant for patients with scleroderma. But the problem here is that we don't have any clinical trials to look at the impact of drugs with just that new definition, that soft number, what we call mild or borderline pulmonary hypertension. So that's a concept that you should be aware of as well. The other new concept, and it has sort of grown from the research world in the diagnosis of pulmonary hypertension relevant to scleroderma, is the concept of exercise testing. So when we do a right heart catheterization, the patients come to the cath lab, they're given medications to make them comfortable, and they're at rest. They're basically sleeping during the procedure, and we measure the pressures. What is recognized now is that it is possible that pressures at rest are normal, but when a patient is walking or exerting themselves, when they really have symptoms, is that those pressures could be abnormal. So what we're starting to do is evaluate the pulmonary vascular response to exercise, and understanding that as a definition. There's been a lot of attention by the colleagues that you hear from, Dr. Chung and others, in identifying a population of scleroderma patients that are at risk for developing pulmonary hypertension. And those are the pre-pulmonary hypertension patients. The belief is that exercise is a way to diagnose those patients earlier. So in this graph, on the y-axis is the pulmonary artery pressure, the mean pulmonary artery pressure, and the x-axis is the cardiac output. And as you exercise a patient, usually the cardiac output increases on the x-axis from low to high. And that response, we could measure what happens to the pulmonary artery pressures. In a normal cohort of patients, the slope of that line is very shallow. In patients who have pulmonary hypertension, the slope of that line is steep. And so the studies that have been done in scleroderma identify the threshold of a slope. I'm sorry, it's not showing up very well here, but a threshold of 3. A slope of more than 3 identifies exercise-exacerbated pulmonary hypertension. And what you'll see here is the squares are normals. The sort of the open squares, sort of diamonds, are scleroderma patients. So you see the slope of the line is a little bit more acute than normals. Those scleroderma patients that have pulmonary hypertension or even borderline pulmonary hypertension have a slope that's more than 3, and those patients with significant pulmonary arterial hypertension have a very steep slope. So when you're being diagnosed for early pulmonary hypertension due to systemic sclerosis, or you may actually even participate in clinical trials or studies that will say, we want to see how you exercise, and we want to see the response of your pulmonary vasculature before and after a therapy, for example, to exercise. And this is a sort of a cutting edge concept, one that has been brewing for almost a decade now, but it's really prime time. And I think you will begin to see this in both the clinical and research settings. So I want to just shift a little bit to say, what are the treatment options that exist currently for the diagnosis of group 1 PAH? And all of these patients are applicable to patients with systemic sclerosis. So there is traditional therapies like supplemental oxygen, diuretics that reduce the volume, sometimes anticoagulants, not usually for systemic sclerosis patients. But the PAH therapies that have been approved fall into 4 categories: the prostacyclins, the endothelin receptor antagonists, the PDE5 inhibitors, and the cyclic guanylate cyclase activators. All of these therapies have been tested in group 1 PAH and approved currently, and all of them are available for use in patients with systemic sclerosis. I'll come back to this in a second, but studying scleroderma only cohort of patients creates a major challenge for investigators in a rare disease. And I was one of those investigators studying an or an immune suppressive therapy that I'll talk to you about. So one of the concepts in scleroderma associated pulmonary hypertension is not only this issue of overlap of you might have lung disease, you might have heart disease, but also how do we identify those patients which are the rare of the rare and study them specifically with agents? And I'll give you a couple of examples. One of the neat things about the recent investigations in PAH that are related, that could relate more to systemic sclerosis patients, is the use of immune modulating therapies and those that have impact on metabolism and fibrosis that may be related to the mechanisms relevant to just all scleroderma. And I think that that's the most exciting part of things. But I'd like to speak initially with about a couple of therapies, the endothelin receptor antagonists and the PDE5 inhibitors that are used as combination, and then get into some of the immune therapies and an example of that in a second for you. This concept, what I was mentioning a little bit earlier, is that there are many investigational agents and their mechanisms listed on the slide that are relevant not only to pulmonary hypertension as it exists today as vasodilators, for example, on the right-hand side, but concepts that have really brewed but have come to the forefront of therapy. We know that obviously inflammation is a major player and autoimmunity is a major player in systemic sclerosis. Well, now we have therapies that we're testing that their mechanism of action is through, impacting that inflammation and impacting the immune cells that are responsible for the inflammation and autoimmunity that is as a part of systemic sclerosis. So it's very exciting that we're testing now strategies that for pulmonary hypertension that have a mechanistic relevance to systemic sclerosis. The others that have the same kind of relevance include the extracellular matrix remodeling agents, elastases and metalloproteinases that are being tested currently now. And there is a good amount of evidence to show that mitochondrial metabolism and neurohormonal activation is abnormal across scleroderma. And we're testing therapies that impact that for pulmonary hypertension as well. So it's an exciting era in research for therapies for pulmonary hypertension, but more and more relevant to systemic sclerosis. So the first thing I'd like to talk to you about is the combination of ambrisentan and tadalafil an endothelin receptor antagonist, and a vasodilator, tadalafil, as upfront therapies for patients with systemic sclerosis associated PAH. This is the work that was led by our colleagues at Johns Hopkins, and we were fortunate enough to contribute. In this study, we studied 24 patients in an open label study of the combination therapy for about 36 weeks, and we studied them for the dual upfront therapy. They were treatment naive at the beginning, and we studied their hemodynamics. We studied their walking capacity, how they felt, how they functioned, and their cardiac function as well. And what was really interesting is here is a table that I'll show you from baseline to week 36, which was the endpoint. And if you looked at the bottom where it says functional status, one of the primary things that we'd like to look at is the 6-minute walking distance. And in this study, the baseline 6-minute walking distance of these patients were 343 meters that went up to 395 meters. So those patients were able to increase their walking distance by a whole 50 meters, which is really great to see. They reduced their reporting of symptoms of breathlessness. The dyspnea Borg score went down, and the functional class, how they felt with pulmonary hypertension and their exercise tolerance as reported by them, appeared to lessen. A majority of the patients went from a class 3, which is a fairly advanced set of symptoms, to a class 2, a reporting of functional status. But what is really most impressive in this study are the impact this we could show in the pulmonary vascular resistance, the occlusion of those blood vessels in the lungs, and the higher the occlusion, the higher that PVR number. So you see that number on a median level went from somewhere around a 6.5 to somewhere less than 4. And you see a tremendous change in a variety of patients, majority of them going from a very significant amount of pressure or resistance of more than 8 Wood units down to much lower. At the same time, when we look at the right ventricular ejection fraction, so the contractility of the right heart, we could show that over a period of 36 weeks, these patients benefited from these therapies by increasing their ventricular fractional ejection fraction, so how active that contraction of the right ventricle was. We were basically feeling that we were rescuing that right ventricle from a failure state in at least a good proportion of these patients. So this data was published in 2015, and it gives you a sort of a clue that the routine therapies that we have for pulmonary hypertension, in this case, dual upfront therapy, was beneficial for patients with systemic sclerosis. Very unusual to have a very small study that focuses on systemic sclerosis. So to round this out here a little bit for you and to finish up, I want to talk to you about a study that the NIH, the NIAID sponsored in the United States, led by myself and Mark Nichols here at Stanford. And we postulated that B-cell depletion using rituximab could be effective as a therapeutic for pulmonary arterial hypertension in patients with systemic sclerosis. So we proposed a randomized double-blind control study of patients with systemic sclerosis who had had the disease diagnosed with at least PAH for less than 5 years. So they didn't have a fibrotic component of disease. Fibrotic means that the blood vessels still had some inflammation that we could address. And we looked at the role of rituximab. I have to tell you, this study was very difficult to complete. And in fact, at the end of the study, we had recruited about 62 patients over an 8 to 9 year period of time. And the difficulty just really identified the issue that we have in studying systemic sclerosis, that there are only a few expert centers, or a growing amount. You have wonderful in organizations like the Scleroderma Research Foundation that can be partners to enable this kind of study. And I think that that's a challenge that needs to be met going forward if we're going to investigate, very sort of critical and specific therapies for systemic sclerosis. So I'll just pass this on by saying that there was a well-controlled study, rituximab patients, about 29 and about 28 placebo patients that received the drug over a period of the study. And in short, to say that the primary endpoint of the study was the 6-minute walking distance at 24 weeks, and the secondary endpoint was the same measure but modeled over 48 weeks. And we showed a significant improvement of about 25.5 meters placebo corrected over 24 weeks with the therapy, but we didn't hit the primary endpoint. And one of the reasons is we missed it by just a couple of feet. But we believe in blue, the rituximab demonstrated an improvement in exercise capacity compared to placebo patients. And what is interesting in blue here is you could relate that improvement in exercise capacity to the reduction of the B cells. So the B cells are shown here in dashed lines, both in the blue, the rituximab group, and in the placebo group. And you see that placebo didn't affect the B cells at all because that was just saline. But you see that patients who received rituximab, their B cells went down. And by 24 weeks, they were at a very good low level. One of the mistakes that we made in this study is we didn't redose patients with rituximab. And I think we really, really should have tried to do that. We showed that the therapy was safe for patients. But at this point, the study wasn't well powered enough to prove an efficacy. So unfortunately, it's not an FDA-approved agent for the treatment of PAH associated with scleroderma, but I think it's something that needs to be studied, a concept that needs to be studied. And then finally in this study, what we did was the last bit, and I'm glad to share the publication with anyone who's interested, is we used machine learning and artificial intelligence to identify the signatures of patients who would respond, who had the best response to rituximab. And we published that information. And I think that's something that we can now do using technology, using aggressive potential immune therapies to really address a subtype of PAH as here, a systemic sclerosis associated PAH. There are many, many studies that are ongoing. Some of them have failed in pulmonary hypertension that are relevant to systemic sclerosis. One, unfortunately, failure was the mitochondrial drug bardoxolone methyl. But there are many, many more to come. And we're really looking forward to those therapies that are immune modulating, especially the study of tacrolimus, which is going to be going fairly quickly. A couple of agents addressing BMPR2 signaling, which we know that's relevant in scleroderma, and a whole bunch of other studies hopefully coming forward evaluating inflammation and autoimmunity. So I really appreciate your time today, and really excited to be in this forum. Looking forward to taking some questions. But ultimately, my point here is there's a lot of exciting research and a lot of exciting clinical developments in relevant to systemic sclerosis and pulmonary hypertension, but the challenges exist for enrollment as a subclass of a rare disease. And I think organizations such as the Scleroderma Research Foundation are really at the intersection point of enabling novel research in a population of patients that it serves. So thank you very much for your consideration and your attention, and I'm looking forward to taking your questions. All right.
Thank you, Dr. Zamanian. Dr. Zamanian is truly an expert both nationally and internationally within the pulmonary arterial hypertension world. Unfortunately, Dr. Zamanian will not be able to participate in the Q&A session. What I plan to do is ask myself a few questions and address those from the ones that came in during his presentation. First of all, there was a couple of questions about becoming involved or learning more about clinical trials. And a few things I would say there. First of all, is speak to your physician at your center who you're seeing for your scleroderma. Those rheumatologists work very closely with the pulmonary arterial hypertension doctors who are typically a pulmonologist and cardiologist, depending on the center or both. So they work very closely together. So that's a great resource, is to ask your doctor. Secondly, there's clinicaltrials.gov, which highlights all of the trials in all the disease states. It just takes a little time to find specific ones on PAH. And then thirdly, if you're looking for specific scleroderma trials, as mentioned before, you can go to the Scleroderma Research Foundation website, srfcure.org, or specific to pulmonary hypertension. The Pulmonary Hypertension Association has a website, and they have a research section, and that'll narrow it down a little bit more into those trials that are for PAH. So I hope that is helpful. Another topic that came in is related to the causes of pulmonary arterial hypertension. And we've come a long way in the last 10 to 15 years in pulmonary hypertension, much like we have in scleroderma. And looking at registry data from about 15 years ago, about half of the PAH patients had an associated disease such as scleroderma or congenital heart disease. So there was a disease associated with their pulmonary hypertension. About 45% were known as idiopathic, meaning we don't really know what the cause was. And then there was a small percent, 5%, that was considered what they called familial. And those, patients, you essentially, it was hereditary in those patients. A decade since that, we've seen a shift, and we've learned a lot during that time. So there's still about half of the patients that get PAH have an associated disease, again, like scleroderma, congenital heart disease, drug use, methamphetamines, cocaine can cause PAH as well. The idiopathic number, those that we don't really know the cause, that's dropped about 10 percentage points to about 35%. And then this familial, which is now called heritable, is up to about 15%. And you've heard a lot about genomics and genetics today, and similar in pulmonary hypertension. There is a lot more availability of genetic testing and a much better understanding, which is really nice, because that gives the scientists and the clinicians the opportunity to really target these novel therapies within the treatment paradigm and treatment development. Let's see, I'm reading another one. So this is related. Dr. Zamanian spoke to these novel treatment targets that are being looked at. And I think he highlighted a couple of the drugs. Just right now, for your background information, and the first drug was approved for pulmonary hypertension in 1995. So it's been fairly recent that we've had therapies, and since 1995, up until actually last week, we've had 15 therapies approved for PAH, which work across 3 different target pathways. And what's really exciting, as Dr. Zamanian spoke to, are these novel therapeutic targets. And now we're seeing a lot of clinical studies and development, some early stage, some later stage in this area. And I'll just mention three. The first is the most recent. They're in phase 3. It's called sotatercept. So they're in phase 3 clinical development, which is kind of the final step before approval. So you could potentially see a therapy like that out within the next 12 months. There's a couple in phase 2 that I'll highlight. One is rodatristat, again, working on a novel target, and that's in phase 2. And another in phase 2 that's getting a lot of press is seralutinib. And again, that's in phase 2, so that's probably a few years off in clinical development. And then the last one I'll mention is actually an inhaled form of one of the drugs that's already approved. So it's just a new formulation. It's not a new pathway. And all of these trials, both for the first 15 drugs approved and the novel ones that are in development, all include PAH patients with scleroderma. And the trials, it's usually in between 10 and 30% of the trials have associated scleroderma. So that's really exciting, I think, for the patient population. So I'm looking, there is, okay. There's a couple of questions that come in. I think the staff have answered about specific treatments. And the best advice there is to speak to your physician about that. I see one question about dual treatment, and this is one of the great things that we've learned in the past 5 to 7 years, 5 to 8 years, is the benefit of using dual treatment to treat PAH. And that's been confirmed by a number of significant clinical trials in this space. So that's becoming more of the norm, is for PAH patients to be on multiple therapies, could be 2-3 therapies. And then as these emerging new treatments come out, we could see 3 or 4 therapies for a given patient. So I'm not seeing any more questions. So why don't we wrap up this session, and if any other questions come in, we'll definitely get back to you with the answers. But much like the other sessions, there is going to be a short survey. So if you will please take a minute and complete that, we would greatly appreciate it. And that'll give you, you'll have enough time to do that before the final session of the day. So thank you everyone for your participation.